This is my husband Larry
How you do?
and my mom Sandy.
How you do? All right, let's see. So we met back in January.
Yes.
Had some tremor that Dr. Chapman had been looking at, I guess, for a few years over at
Yes.
Baptist. Nothing had really kind of progressed to an answer. And
Right.
when I saw you, we talked about a few things, but mostly some concern that you had some subtle signs of Parkinson's. A little bit when you were kind of distracted and had you doing other things. There's a little bit of kind of some resting tremor, a little bit of slowness and stiffness on the right side.
Yes.
Sort of things that we can often see early in Parkinson's. And we talked about, well, the fact that you've had these symptoms for 3 years without a really big change in that is a little unusual for Parkinson's, but you have a little Parkinsonism. We're going to put you on a medicine to see if it helps. In the meantime, we'll get some workup to find out what exactly we're dealing with.
Right.
My impression, what I've got from your note and from, I think, when Angie talked to you, is you felt like the medicine helped.
I thought it did. I mean, I felt like it did. It didn't stop the tremors completely, which they tend to be all over at this point. I vibrate. But it did help with like the gait. Like I didn't shuffle, and they observed that as well. I felt more light on my feet and able to pivot and that kind of stuff.
Okay.
And my line of work, you know, I'm a kindergarten teacher. I'm always moving around the room, and that became easier.
Okay.
So that's where I saw the improvement, was more the gait and the balance and things like that.
Okay. And so in general, we don't expect the medicine to help if somebody doesn't have Parkinson's disease. Now, sometimes it can just be placebo, right? It's like, I'm getting a treatment, this is going to work, I feel better, and I'm moving better. That's possible too. We did the testing because there were some subtle signs of Parkinsonism, a little bit atypical clinical course, and not the other kind of non-motor features and things. So it's not, when we look at clinical criteria for diagnosing Parkinson's, you didn't meet criteria, but you had some subtle signs. So the skin biopsy has upper 90s sensitivity and specificity for Parkinson's, for degenerative Parkinsonism, and yours was normal.
Right.
Upper 90s doesn't mean that there's not rare cases where it's wrong,
Okay.
but that part's reassuring that you don't have Parkinson's disease.
Okay.
The reason we got the MRI was because of the atypical course, to make sure that this wasn't something, for instance, like a stroke that had happened, that it's rare, but on some occasions we can have structural things in the brain that will cause some Parkinsonism, a stroke, a brain tumor, something like that. It's exceedingly rare. I had this discussion with my colleague yesterday, who I think he did your biopsy, right, Dr. Crowell?
Yes, yes.
We were talking about a different patient, but as far as, kind of how aggressive are you in a workup in a young person with Parkinson's, where you're just pretty convinced they have Parkinson's. And the thing is, if you look like you have Parkinson's and your clinical course is consistent with Parkinson's, you don't really need those workup. But yours was not. It was a little unusual. So we got the MRI. Your MRI looks fine.
Right.
It looks, you had gotten one in like 2016.
Yeah.
Got some microvascular changes, which if I did MRI of my brain, I would too, and so would you, and so would you, right? So normal for age. I don't see anything that would correlate to the Parkinsonism. So now we're at a place where you have some tremor, and that all over vibrating thing is not really probably tremor, and so I don't know that that'll be made better. So tremor is when you're physically shaking, and I see that right now, and you all can probably see that as we talk.
Yeah.
She's got some tremor of her right hand. Right?
I didn't take the part, don't believe it was there, because I wanted to see for myself too.
Yeah. So
I mean, I can feel it wear off, and then when I take it, I feel back to normal again.
You feel like it's helping.
But so it does help. Like I know especially during the school day when my stress levels are the highest, that 3 o'clock pill, I know when it's coming.
You can tell when it's time.
Yeah, like I can't even type on my computer. I can't do that. Yeah, I'm packing with my left hand at this point.
And so now we have levodopa responsive Parkinsonism without evidence of Parkinson's disease, which is good. It's good we don't have evidence of Parkinson's disease, but I don't have an explanation for why the medicine would work otherwise, but it does. So there's really no reason not to take it.
Right.
It helps. So worst case scenario is you really do have Parkinson's and it's helping, and we just can't define it yet. If you do have Parkinson's, you have an unusual clinical course which is very slowly progressive, which is also good.
Okay.
And where it's not diagnosed by those tests. There's one other test we could add called a DAT scan. We could add that, but honestly, I don't know that it adds much more to the picture. Because if it disagreed with the skin biopsy, I'd say, does the medicine help? And you said, yeah, I'd say to stay on it. If it agreed with the skin biopsy, and I said, okay, well, we have two things that suggest you have Parkinson's disease, and you said, does the medicine help? I'd say, well, then stay on it. So your differential for what this could be is Parkinson's disease that was missed by the testing, that's slowly progressive and responsive to appropriate treatment, which could be some kind of other atypical Parkinsonism. Not, and again, I don't have concerns for something, so like, don't go online and search atypical Parkinsonism, because then you're gonna think you got like PSP or something. It's not that.
Right.
Whatever this is on the benign end of the spectrum, not something that's severe, right? Because you've gone 3 years without even a diagnosis.
Okay.
So this is not dementia of Lewy bodies or progressive supranuclear palsy or any of those kind of ominous sounding things.
Okay.
This is, some kind of slowly progressive or non-progressive focal right now Parkinsonism that seems to respond to the medicine.
Okay.
The other thing is, could it be a placebo effect from the medicine?
Okay.
And could your symptoms have been something that are triggered just by stress?
Of
That's a possibility
big-
as well.
I have chronic stress. I mean, I'm a teacher.
And everybody
police
has,
officer.
everybody has stress,
Yeah.
right? Like,
But I mean, it's,
and some people, the way that their bodies and brains deals with stress are different.
Yeah.
And sometimes that can manifest, and that's what Dr. Chapman's diagnosis for you was what's called enhanced physiologic tremor, right? And that's the tremor that all of us get if we get anxious or stressed, we shake, right? And some of that, when people say, I feel like I'm shaking all over, and they're not, that's inside, that's not actually tremor. I feel shaky, that's anxiety, right?
oh yeah.
And anxiety can correspond with tremor, with actual tremor. That's enhanced
Right.
physiologic tremor. So I have essential tremor. Mine's not too bad today, but but at the end of the day, it might be,
Yeah.
right? Or if somebody comes in here and
Yeah.
it'll get worse. People that have Parkinson's tremor, even their regular Parkinson's tremor will get worse when they're anxious or stressed. And people that don't have any tremor at all will shake.
Yeah.
So there's maybe a component of that. And then there are also people that it's rare for me to see functional or psychogenic Parkinsonism. I see psychogenic movement disorders, but rarely does it manifest as something that looks like Parkinson's. Usually, when we see a movement disorder that's psychogenic, that's basically the mind manifesting as physical symptoms to deal with stress, there are signs on exam that tip us off, right? That's where like somebody's tremor is distractible or entrainable or that sort of thing. I didn't see any of that on your exam. So I'm always, every patient I see, I'm looking for signs of that, right? Because if your main problem is actually stress, and we just treat it as Parkinson's, we're not making you better.
Right.
We're giving you a new diagnosis and masking the one that's actually the cause, right?
Right. But just to kind of back up and refocus, my biggest complaint wasn't the tremor in the beginning, it was the loss of motor skills on my right side.
Yeah.
Because that was what was affecting my job.
Right.
I mean, I model handwriting on the big screen for the kids. Mellow worksheet where we're coloring the lines. I can't wave. Like, there's just like certain things on my right side I can't do. And then I was losing my shoe as I was walking. I can't wear a flip flop anymore. And these were things were happening 3-4 years ago.
Yeah.
They had gotten worse, and then I walked funny, and people were noticing it and asking me if I've hurt myself. So it was really, the tremor to me was, in my mind, part of stress.
Yeah.
It's gotten worse. The resting tremor has gotten worse, I think, and that could be the placebo or the fact that I've been told this. But my biggest concern and getting dressed and brushing my teeth and washing my hair and putting on makeup, that is like exhausting for me.
And that's better on the medicine.
Yes.
Okay.
But that's probably the hardest thing, is just the daily grooming, and I mean, I'm exhausted when I'm done just thinking through. Like, I do more with my left hand than I do with my right hand. I eat and do everything I can with my left hand at this point. My right hand just lays like it's in a sling.
Yeah.
I do see it go crazy when I'm like yelling at the class. The kids will, my assistant starts looking, and it's obvious, it starts going. But the biggest thing is just the loss of use of my right. I mean, I can't even the days of a typewriter. I know how to, I can type, I knew how to look at a piece of paper and type, and, I know my home row keys and all that kind of stuff. I can't even do that anymore.
Yeah.
So I'm hunting and pecking on the computer, and I'm pretty quick with it now. I mean, I've kind of adapted to my left hand. The only thing I can't do is write with my left hand, and I can color if I'm modeling paper or something like that. But that's probably my biggest concern, as far as, because sometimes when the tremor gets going, I'll take a Xanax and that'll kind of calm it down. That's kind of where that 4 times a day came from. That's when we were trying to figure out where the tremor was before I even landed in your office. Before that, I was prescribed 1 a day, and then it kept increasing to chase the tremor and to chase that anxiety.
Yeah.
from a psychiatrist, but my concern, which I kept bringing up since, I mean, at one point I was and of course the stiffness and pain has always been present in my life too. I've always had the shoulder issue, and I've always had stiffness in my calves since I was young. I've always been stiff in the mornings. But I've even been tested for RA because I said it's kind of like a phantom. I'll have this pain come, and 3 years later it'll come back. Like I've been in therapy twice for arthritis in my right foot, which is the top bones here because I literally can't walk.
Yeah.
And spent the whole summer trying to rehabilitate to go back to work the next year, and then it goes away from 2017 to 2019. It comes back, or no, 2021. So anyway, it's just I'm chasing stiffness and pain and the loss of my movement.
Yeah.
So really, the tremor is not my biggest concern.
And the
I mean, it
tremor's only a
is.
piece of the puzzle from the standpoint.
It's a piece, yeah.
You know, the slowness and stiffness are also the things that are symptoms or signs of Parkinson's.
Yeah.
Of Parkinsonism. And so again, that's the question, and not just for the tremor, because tremor can be, stress related from a physiologic standpoint and not a psychogenic standpoint. But when we talk about something that's otherwise psychogenic, or basically the mind's way of creating symptoms to cope with stress, the slowness and stiffness can be that too. And so that's what we really have to try to determine. And again, usually when I see patients who come in with a movement disorder related to stressors of life, right? And that can be my job's stressful, but it's usually more commonly related to I've had traumatic stress at some point in my life previously. Childhood, sexual abuse is a common thing that's a trigger to that. So these are usually not, I have to deal with the classroom of screaming kids all day, right? It's usually something more significant and remote. Doesn't have to be. There are people that have psychogenic movement disorders or psychogenic neurologic disorders who don't have any kind of associated trauma or kind of stressor that would be the reason. In those cases, we don't know. Does that feel cold down there?
Yes.
Same temperature on both sides, up and
A little
down.
colder on the left.
A little colder on the right. You feel the buzz?
Yes.
That's the same in both.
Yes.
The same up here as well.
Yes.
Look right across the roof over there. Follow my light with your eyes. Relax your arm here for me as loose as you can. And open and close your left hand. Sometimes we'll do facilitation maneuvers where I have somebody on the other side make some movements to see, because her tone is, and I'll have you feel it too. Her tone is relatively normal, kind of both sides. I'll let Taylor move your arms around here too.
Okay.
She's not particularly stiff there. Open and close your left hand for me again, please. But it does stiffen a little bit there when she does
I do
that.
yoga a lot.
Now feel her left.
Feeling better since I've been doing that.
It's pretty loose.
Yeah, now open and close your right hand.
Okay.
Just a little bit, but that, so it's fairly symmetric. And let's have us try another thing. So let's have those hands just relax. Close your eyes. Say the months of the year backwards.
December, November, October, September, August, July, June, May, April, March, February, January.
Good. And now open your eyes with your left hand. Tap like this for me.
This one,
With your left hand.
left hand.
And then open and close like this. And then do this. Okay, and then relax again here for me. And now with your right hand. like this.
My toes starting to curl. When I'm working hard on my right hand, it curls.
What's that one does?
My toe.
The toe curl.
Toe curls and then my calves are tight.
And then open and close your hand like this. Like this. And then stomp your foot like this. And then this one. And relax here, nice and loose.
I tried a cardio class and I couldn't dance anymore.
Try this one and cross your arms and stand up. And let's go walk a little bit. Sit down all the way. Alright, come on back.
I wore tennis shoes to school one day and I stumbled about 5 times with more traction.
Yeah.
And then I fell in the classroom one day too.
Alright, come on back. So overall, things look still, about the same. It's not a clear-cut case of Parkinsonism. Your right side is a little slower and stiffer. There are some things that are not typical of Parkinson's, right? So a little bit of tremor intermittently as we were talking, but nothing when you're kind of distracted and we're not, it didn't reemerge, it didn't come back out. Your slowness of your movements, we don't see decrementing of movements like we would typically see in Parkinson's. So it's just overall some slowness, not a whole lot of stiffness. So some subtleties. I would still call it Parkinsonism.
Okay.
It still begs the question of what it is. And I think our differential diagnosis of what it is some kind of neurologic Parkinsonism, most common of which would be Parkinson's disease, right? We don't see anything structural. There's not a brain tumor, there's not a stroke, there's nothing structurally in your brain that's abnormal. And we don't find any evidence using a test with a high sensitivity and specificity for the pathology of Parkinson's disease, because even if you had Parkinson's disease, I would expect your MRI to be normal.
Okay.
So a normal MRI doesn't preclude Parkinson's, it precludes some other structural cause. You're not on medications that should cause Parkinsonism. You don't have evidence of Parkinson's pathology. So at this point, without compelling evidence, so again, usually when I see somebody who has a functional or a psychogenic movement disorder, there are findings on their exam that are supportive of that. I don't see a lot of that on your exam, okay? So it's usually, fortunately, when the mind's playing tricks on the body, it's not very good at it, doing it from a way that the nervous system normally happens. So usually we can tease those things out on exam. That doesn't mean we always can. So the things that we're considering is either something neurologic, Parkinson's disease, that's just being missed by the test, and we could order another test to kind of help determine, or something that is, again, an unusual presentation of, but possibly, when I say stress-induced, something psychogenic. Again, whether it's related to current stressors, previous lifetime stressors, or even none of those. The brain's way of manifesting symptoms that are not neurogenic in origin. Right? So the brain is our psyche as well. So it's kind of arbitrary to separate that. Maybe when we think of psychiatry and neurology, but that's just how it's done, unfortunately, is this kind of dualistic approach. All that to say that if this is psychogenic, right, this is a psychogenic etiology of Parkinsonism, medicines don't make it better. The treatment for it is therapy, and that's usually a combination of physical therapy and psychotherapy. Okay, and it's best if it's done in the hands of somebody who understands what a functional neurological disorder is. Because we just go to most people that don't know what that is,
Right.
and they'll say, "Oh, this is not caused by this is not depression, this is not anxiety. Those things can worsen it, but it is something else. It is a diagnosis of its own, if that's what it is."
Right.
Alternatively, it's is it Parkinson's disease? Could be, although again, we're not meeting criteria for that.
Okay.
If the medicine helps you, it's not a harmful medicine. it doesn't cause organ damage, it doesn't cause worsening of any disease. If it caused side effects, then that would be the harm, but it's not going to hurt you. We don't need to do labs on it. It's not going to cause kidney problems or liver problems or anything like that. It's safe to use. And if it's helping, even if it's just placebo effect, it's still okay. It's making you better. The thing we don't want to do is mask something that's something like deep-seated, stress-related, and mask it while we treat with medicines for something that's not really there.
Right.
So there's no problem with staying on the levodopa.
Okay.
Are you still seeing a behavioral health provider, a psychiatrist, or a therapist?
I have to get my Cymbalta and my
Okay.
Xanax. I see him every 2 months, but it's
Okay.
it's 5 minutes.
Who is?
Dr. Kadir,
Okay.
local behavior therapist. And I've asked for a therapist, they don't even get back with me.
And that's
It's
the problem.
poor care.
We can ask Brian Davis, who's one of our psychologists, maybe for some guidance there, because I think, regardless of which of these things it is, therapy would be beneficial.
Mm-hmm.
Uh,
Yeah, I've asked for one.
And I think, if the medicine helps, keep taking it. Really you say, well, what do we do? What else can we do? Well, if you have Parkinson's disease, this medicine is the treatment for the symptoms. There's not a different medicine for the symptoms. You're tolerating it seems to help, so we stay on medicine. There's not a treatment that slows down and prevents progression of Parkinson's disease. So even if we said, so if you weren't taking this medicine, it's not harmful to you,
Mm-hmm.
nor is it harmful to take it. If you feel like it helps, take it. There's no other treatment you need to be on if you have Parkinson's, or for anything else that would cause this Parkinsonism, other than if it was psychogenic in origin. That needs to be addressed. And I don't do that because I'm a neurologist. So that's where the psychiatry or the behavioral health comes in. Otherwise, the only thing that's been shown to slow down progression of Parkinson's disease is regular exercise. I'm going to recommend you do that whether you have Parkinson's or not, right?
Yeah.
We all need to be doing that.
Right.
30 minutes aerobic exercise 3 days a week. So if you say, if I do have Parkinson's, what can I do? You can exercise.
Yes.
You can take this medicine if it helps, whether it's actually helping with an underlying Parkinson's that wasn't diagnosed by the test, or whether it's placebo, who cares? It's making you feel better, you're functioning better, it's not harmful, it's not causing you side effects. Keep taking it. We need to watch over time to look for evidence of typical progression to something that is more likely diagnosable. The longer we go, and I don't see things that are typical of Parkinson's, the less and less likely it is that it's Parkinson's disease.
Okay.
So what I would recommend we do is we try to maybe get you established with Dr. Davis or somebody from his group or recommendations for that. Continue on your carbidopa levodopa.
Okay.
We might want to consider getting a DAT scan.
Okay.
Just to have, because like I said, if those disagree, we're sort of just going to follow it clinically. If they're both negative, it argues even further against Parkinson's.
Okay.
We do a DAT scan, stay on the levodopa, continue to follow it clinically, and see how things go. But don't discount the potential for traumatic life events to cause something that looks and behaves like Parkinson's.
Okay.
And without us spending a lot of time as a not behavioral health professional delving into your background, that needs to be something discussed with a therapist. Because even if it's not the actual cause of this, it still plays a role in your life, in your overall life. So I would say leave your medicine alone. It's helping, keep taking it. As long as you tolerate it and you feel like it's helping. That addresses some of the motor issues. Doesn't address everything, but we still have a little bit of work to do. So I'm going to go and order the DAT scan today. I will send a message to Dr. Davis today to kind of ask him what's the best approach. If you haven't heard anything from us by like next week, middle to end of next week, send a message over and say, hey, what's going on? We're going to talk to Dr. Davis. Because sometimes those things get lost and he didn't respond, or he did and then it didn't,
Right.
So once we have a plan, we can kind of put that in motion. But let me talk with him first. It could be a Friday, he may not get back to me today, so maybe the first part of the week. So give us a few days to try to figure out what's the best approach for that. As like you said, I guess working with Dr. Coder, trying to get therapy hasn't really come to fruition, so we'll try to go at it from a different angle. Okay, so we should be good there. let's go, let's see, make sure. You've got other appointments already on the books, so for now, just leave your appointments where they are.
Okay.
I'll see you back in February,
Mhm.
and then depending on where we are, we might go ahead and just keep that Parkinson's multidisciplinary clinic. Just
Yeah.
as because one of the things we do in that is an annual diagnosis
Yeah,
review,
that
so
was
to give us
suggested.
an idea to just kind of go through everything, review the diagnosis, and if we still, at that point, we say, look, you've had a normal DAT scan and a normal biopsy, you don't meet clinical criteria for Parkinson's, we may be able to more comfortably say this isn't Parkinson's disease, but at least we can look at it that way. So I would
Okay.
just leave everything the way it is on the books while we try to get you the help you need, and we'll follow along. Sounds like a fair plan. Let's go put it in motion. Come
Okay.
on with me. Are we done?
We're done.
Yep. We'll wait to check out.